late. It's 9 o'clock. I think we'll get started. Good morning, everyone. We are just so happy that you guys are here on the very last day of conference. We're also really happy we're just not talking to ourselves. So really thankful that you're here. We will be presenting the top medical education articles that were published in AEM Education and Training Journal in 2024. I'm Esther Chen. I'm one of the decision editors for the journal. I'm also faculty at the University of California at San Francisco. And this is a session that we have the privilege of presenting sort of every year for the last 2 years. So we're very happy to be here. Susan Promise, who is our editor-in-chief, unfortunately she can't be here today. She usually does the introductions. And then Dr. Jamie Jordan, who is also on the editorial board and one of the, and sort of part of our article selection committee. She is running a session at the Consensus Conference, and so she is not able to be here today. So it's my pleasure to introduce our presenters. So Dr. Ivan Zvonar, who is from the University of Washington and Harborview Medical Center. He's also one of our editorial board fellows this year. Dr. Nilu Tabatabai, who is from the University of California, Davis, and also one of our editorial board fellows. And then Dr. Michael Gottlieb, who really needs no introduction, who's the professor of emergency medicine, as well as the vice chair of research from Rush University. And then, of course, Dr. Jamie Jordan and Dr. Promise, who unfortunately couldn't be here today. And I just learned that Dr. Jordan, I think, now has a new institution. She is now at OHSU. So that was news to me. We are all of the presenters are part of the editorial board, and so that is our disclosure. And we're really hoping that by the end of this session, you'll be able to identify just some impactful articles from the 2024 issues of AEM Education and Training. You would be able to discuss how these article findings might improve sort of all of our understanding of some really important topics that we've been talking about in emergency medicine, education, and training. And then most importantly, sort of how do you take away some of these article conclusions and really apply that to improve your own or your faculty's education and training of emergency medicine residents. So with that, we'll get started. And I'll advance the slides.
Like Esther said, I'm Ivan. Thank you guys for taking the time. So we'll just jump right into it. This first article, as you can see, is titled ChatGPT, Comparing Large Language Model, Artificial Intelligence, and Faculty Rankings of the Competitiveness of Standardized Letters of Evaluation. Just as a raise of hands, who pronounces it slow? Do we have any slowies? Okay. Oh, interesting. Okay. So this is a brief contribution, which is a submission type that we have that's similar to an original contribution study, just with a shorter word limit for some smaller work. This is a multi-institution working group based off of a CORD working group. And I figured you can't go to a talk at an EM conference these days without talking about AI, so we'll just get this out of the way on the first article, and then we'll be done with it. But as the title suggests, kind of thinking about how can we start offloading some of our more time and energy intensive processes to AI and large language models, particularly as we enter an era where we are trying to be more equitable and doing more in-depth holistic reviews. And so this group set out to answer the question of how does a large language model generated slow ranking compare to that of trained faculty. They used 50 mock slows that they've previously published from a prior study and had 7 trained EM faculty go through them and create a ranking, as well as using Julius, which is a combo of ChatGPT, Python, and Excel to essentially go through it. Since LLMs are stochastic and they'll change each time, they ran it through 7 times, and then they gave it 2 separate prompts and then compared the rankings to the faculty. Their Pearson coefficient was very similar. It was like 0.96 on the first go through, which starts raising the thought of, is this something that we can start doing, right? This is something that for faculty takes us on the order of several hours to weeks. And the LLM spits this out on the order of seconds to minutes, which is really mind-blowing. I think it really, the interesting thing was they looked at it and it mostly relied on quantitative and not qualitative data, which really makes us reflect on, are we truly like looking at these things and the qualitative aspects as much as we say that we are? And obviously there are a lot of limitations to this study, but this is a proof of concept, and maybe there is a future in which we learn how to scale up, answer privacy concerns with locally sourced AI networks, and maybe there's a future in which we get some time back to then be able to use that towards coaching and mentoring and other things that we have as faculty.
All right, as Esther introduced, I'm Neely Capitine from UC Davis, and my article is Cold Feet, a qualitative study of medical students who seriously considered emergency medicine but chose another specialty. This article is by Ockhaven all from the University of Washington. So were you ever curious to know the exact reasons EM residency applications fell during the recent cycles? Well, this is an original qualitative research study, which in our journal aims to address or answer new questions or challenges in emergency medicine. And they were, so given the recent downtrends in emergency medicine residency applications, the authors wanted to understand factors influencing students' decision to opt out of the specialty. So what they did is they conducted semi-structured interviews with 16 senior medical students from 12 different institutions who had initially strongly considered emergency medicine, but ultimately selected something different. They did a thematic analysis and found 5 themes that influenced students' decisions against pursuing emergency medicine. The first one is the innate characteristics of emergency medicine, such as the unpredictable work environment, the schedule, the limited flexibility in the practice of it, and the violence in the emergency department. The second is widespread concerns related to the recent emergency medicine workforce report predicting physician surplus, raising concerns for future job security. The third one is concerns regarding high levels of burnout linked to societal failures to adequately address vulnerable patient needs. Fourth is the perceived lack of respect for emergency medicine within the broader healthcare system. And then the fifth is the lack of early emergency medicine experiences. This study is impactful because it brings to light issues contributing to the declining interest in emergency medicine among medical students. It provides valuable insights for residency leadership and faculty by identifying key deterrents. And themes from this article can provide actionable data that can guide interventions and aimed at addressing these deterrents and can enhance future recruitment.
All right, so mine kind of builds nicely on this because it looks at another different lens on a similar question, which is, well, EM, at the time this was put out, EM match rates had dropped. There was a lot of concern about this, but they also identified one other thing, and they identified that there's a relative stagnation in terms of women in emergency medicine, and that the rate was staying at 35% despite trends that were changing in other areas. We were not changing. So they wanted to look at this from 2 pieces. They said they want to understand during the clerkship experience what influences the elements that have you amongst people who actually rank EM as either a top or a co-top choice. And similarly, how does that differ across genders? Like, what are the experiences we see? So they did a qualitative study. They included 25 different senior medical students across institutions. They reached out through listservs and through PDs or clerkship directors to try to identify these students. They did something which I thought was a really thoughtful piece. So sometimes part of this is not just we want to share the articles, we want to share some of the methodology that hopefully inspires you to incorporate these in your styles. Is they had other students interview them because they thought the power dynamic of having other faculty, even if they're in another institution, who are going to be their future potential program leadership or professional supervisors in capacity, might influence that power dynamic. So they wanted to have these students as peer interviewers from other institutions. They trained them up, they had them do the interviews. They reached saturation. So for those who are less familiar with qualitative research, the idea of saturation or sufficiency is a more modern technical term for it. But basically the idea is after a set number of interviews, you can go 2 consecutive interviews and you have no new ideas, like no major new ideas, nothing that's groundbreaking, nothing that changes things. You reach saturation or sufficiency. And they had hit that at 25, or 21. So they did 4 more on top of that to say, let's just be sure. And they went all the way to 25, and they still had no new ideas for those 4. So they believe they had a pretty good sense of what people thought. Then they followed, the kind of typical, data coding, the building a code book, working together to develop these themes, and they identified 4 key themes. And they use this under the realm of professional identity formation. So the other thing I want to highlight before we get into the findings is, when you're doing a study, anything in medical education, but particularly in qualitative, you want to have a theme. It may inform it from the start, and that's a form of methodology, or you may have it put on the discussion end to say, now that we've analyzed this, we're applying theme in later, but there should be some, or should say a learning theory or an educational theory, but you have some educational theory that grounds this together. It's the same way that saying, if you're in PE, you have to understand how anticoagulation works. you're going to understand how, in this case, professional identity formation works, you have to understand the underlying theory. So they tied it into professional identity formation, which is how do we think, act, feel like a position, how do we align with that field. And they identified 4 key things. First, they found that there was just distressing interpersonal interaction between the physicians and staff. So amongst the physicians themselves, they found there was subtle and overt levels of sexism and inappropriate comments, and that, particularly for women, was very distressing and kind of hold back the desire to go into this. They also found that there was discouraging comments about patients. How often have you heard someone say something disparaging about someone's, housing status, they're returning back to the ED? Students hear what we say. And it's important we're conscious of that in ourselves and our colleagues, that what we say, even if we're not talking to them, is heard. And this echoed that thought, that they hear what we say, even when we're not talking to them. Second thing was that the EM culture itself, it can be exclusionary at times. Both the typical, who's seen Dr. Coleman play? What's he doing, right? When he says EM, he demonstrates what we see, what others see of us to some degree, wearing a bike helmet, rock climbing, right? And some of these traits are not always like the most, they may not align with people who don't see themselves this way. So if you're like, oh, all EM docs are adrenaline junkies who want to go climb rocks, you're like, I'm introverted, I don't like that. You may not feel like this field's right for you. And a lot of these, unfortunately, are slightly more masculine-leaning traits as well, which can feel exclusionary towards women. So this was another area where they saw where we need to be conscious of how we portray the field. The third one was that the kind of beliefs and attributes that we attribute to, third one is that the culture itself in terms of how it is in the environment. So not surprisingly, a common theme that rose up was that women medical students were often referred to as nurses, and they were dismissed in a way that men medical students were not. And being conscious of that, how can we advocate for our learners the same way that we should be advocating for any our staff and everyone else? Because I think that that's again something that would just be time and time again, it's going to be demoralizing, and it's going to reduce our hopeful progress to improve parity and equity with our field. And then the last one is that they had just less access to mentors, and they had less access to seeing representation. Some students have said they went 3 or 4 shifts without any women resident or attending physicians they saw. And if you're looking around, you're like, no one looks like me. How are you going to want to feel like you're in this field? They also said in general, and this is more of a generalized mentorship we should be conscious of, is as opposed to internal medicine or other fields where you go block with the same attending, you have that relationship, a block with the same resident, the relationship. We go shift to shift to shift as a new person. How do you build that mentoring bond? How do you develop that connection that drives people to come into the field if you only see them one time and you don't see them again for 3 weeks or never again? And I think thinking through how we can build this relationship through paired modeling or something along those lines. And so really what I took away from this one was twofold. One, they had some really, not surprising, it's an excellent group, really good qualitative methodology, but also for us, even though we are on an uptrend, we're doing obviously like a much better state than we were a couple of years ago, how do we continue to grow there? How do we make sure that we are thoughtful of how we are inclusive towards our students and we build a culture that makes people want to go into emergency medicine?
Now, this next article is entitled Best Practices for Reporting Survey-Based Research. And it's by Dr. Hill from the University of Cincinnati, and includes 2 of our decision editors on the editorial board. And this is part of an educational download series. And so I would encourage you to bookmark this because this is a specific manuscript submission type that is sort of a very brief 500-word discussion of an educational model or concept. And it's really a nice way to sort of present an educational concept in a really easily digestible way, and often contains sort of an infographic that you might be able to use to summarize the important information that's presented. And so this educational downloads highlights some best practices for reporting survey-based research. And it includes an infographic that sort of could work as a checklist for authors as you're drafting or editing your manuscript to really remember what are the important elements that I should include when I'm writing up this survey-based research study. Or you could use it for like a junior faculty member or a resident who who you might be working with, and you're critically appraising an article or reading a research article about survey-based research, and it's a good framework for you to use as you're reading the paper to make sure, are the authors presenting all of the information that's really useful? Are these conclusions valid? And so it's a way for you to really evaluate a piece of research. And so these authors present 2 published guidelines for reporting survey-based research. And so one of them is the 40-item cross checklist, and one of them is the academic medicine checklist for reporting survey-based research. So these are already resources that exist. They're a little lengthy, but this, you could, they refer to it because these are sort of really important resources for someone to use as you're reading or writing your manuscript. And I think it can be, the authors then present some important information and highlight important information that you should include. So for example, if you're in your introduction, you should really make it clear why you're using a survey. Why did you use this format to answer the research question that you're thinking about answering? In your methods section, you really should talk about how you develop the survey and how you administer the survey. And often what we see as editorial, as decision editors, is many times those details aren't there. And so if they're not there and you're doing a survey-based research study, then it's really hard for us to know, are these conclusions valid? Are these are the results valid? And did you really design your outcomes to answer your question? I also really like the 2 caveats that the authors present in this article. And the first is it's really important to tailor your reporting to your study. So even though these checklists are best practices, they may not be relevant for your study, right? The second caveat is that depending on your study, it's really not as important that those specific elements are in the introduction or in the methods section or in the results, but that the information is there somewhere in your manuscript. So it's a way to tailor some of these best practices to your study design. And then more importantly, I think this serves as a reminder that as we're reading a survey-based study, we must consider if all of those elements are not there, in terms of how do they design the survey, how do they implement the survey, do they use MESIC's validity framework for developing or administering the survey. If they didn't do all of those or report all of those, then are their conclusions really valid? So as you're thinking about administering the survey, and I think all of us do, as you're implementing an educational intervention and you want to see how things are going, you want to get some feedback, to consider just a more methodical approach. Before you even administer that survey, think about, are you asking the right question? Is this the right design for what you want to know? And how do you just use this framework to more methodically think about how you're designing your study?
All right, so the next article is titled Effects of Opening Up a Vertical Care Area on Emergency Medicine Resident Clinical Experiences. This group is out of Yale. And I feel like this is my, like the admin folks beefing it out with the residency leadership team. And I think it's something that we're all kind of struggling with as we are realizing that front-facing processes where we have providers in triage that are then sending patients to either fast-track areas or vertical care areas are certainly changing the dynamics of the patients that residents are seeing in the emergency department depending on how staffing models are at your shop. And so this group really set out to answer this question of how does implementing a physician in triage with an associated vertical care area staffed by APPs affect resident education. And so what they did was they used an organizational learning educational framework, which is just a framework to try and understand how learning processes are affected at different levels amongst an institution when you base new system processes. And they looked at a bunch of different parameters. So they looked at how many patients per hour residents were seeing, how many procedures they were doing. They lumped the ESI of patients to 1 and 2 and 4 and 5. Obviously, we can argue at length if ESI is a good marker of patient acuity, but at least it gave them something to look at, and they kind of got rid of the 3s because they really wanted to lump very acute patients with much lesser acute patients. And then they also looked at critical care billing, as well as the number of behavioral health patients that residents were seeing. And so this was a retrospective observational study at their quaternary site that sees about 100,000 patients a year. It's their primary site that the residents work at. They do have 2 other sites that they rotate through. And what they did was they looked at a 3-month period after they instituted this new model. They looked at the 3 months before the institution of the new model, and then they also looked at a 3-month period the year prior in order to have 2 separate controls. Essentially what they did prior to the implementation of the vertical care area was that they had kind of any patient could go anywhere in the ED, and the APPs were interspersed with the residents. They have a model where a 1 and a 4 work as a dyad, and then 2s and 3s see patients independently. When they instituted this new model, they had a physician in triage that would triage patients. 1s and 2s would automatically go back to the ED and be seen by residents. 3s, the provider in triage would decide upon whether they could be triaged to this new vertical care area, or 3s that they deemed inappropriate for that would go back to the main ED, and then 4s and 5s would similarly go to this vertical care area. So vertical 3s, 4s, and 5s would be seen exclusively by APPs. And then the other caveat being that all behavioral health patients would go back to the main ED and be seen by residents. They went ahead and also did a logistical regression with the following covariates, so looking at the ED census and volume, as well as the number of behavioral health patients to try and control for those variables on different days. And basically what they found was, first of all, that everyone had an overall increase in patients per hour seen, that they attributed to just better departmental flow and efficiency. Interestingly, there was no change in the percentage of patients that were seen by residents. So all those percentages were the same. The APP saw a bit more, the residents saw a bit more. There was no change in the number of procedures that the residents performed, which I think kind of makes sense if most of your procedures are being done in patients that are of higher acuity. Interestingly enough, the remainder of what they saw was just a change distribution by PGY class. So the interns started seeing slightly more percentage of higher acuity patients, while the 2s and 3s started seeing a little less of their total patients that were of higher acuity, as those kind of 1, 2s and non-vertical 3s were roomed back to the main ED. The only other thing that they saw was that because none of the behavioral health patients were going to this new vertical care area, there was a slight increase in behavioral health patients that were seen by residents as opposed to APPs. And so, you know, in thinking about this is obviously something that is going to be very individualized from shop to shop, depending on how you institute new staffing models. But I think that as we've kind of come through the backside of the COVID pandemic, as we are looking at an ongoing health system that is really stressing all of our emergency departments, we also have to be thoughtful about how new efficient models impact our learners. And if, for example, in this shop where they are realizing that they are seeing less of lower acuity, the question being that are our residents getting that opportunity to learn how to deal with those lower acuity complaints elsewhere? And for example, at this shop, they argued that because they have 2 other sites that the residents rotate at, that they will get those skills there. So just something to be mindful of, and thinking that as we institute these system changes, how can we ensure that our residents and our trainees continue to get the training that they need to be successful in the future.
This next article is titled "Depression and Associated Risk Factors Among Emergency Medicine Interns Results from a National Longitudinal Cohort Study." This is by Dr. Fulk et al. From Carolina Medical Center. So this article is an original research study. It investigates depression and associated risk factors among emergency medicine interns through a national longitudinal cohort study. The authors recognize that while depression is common among residents, data specifically focusing on EM interns was lacking. Thus, the study aimed to assess the prevalence and risk factors for depression, including sleep patterns, work hours, types of clinical rotations, and demographics. The study performed a secondary analysis on data from the intern health study involving emergency medicine interns across the United States from 2007 to 2021. Over 1,100 EM interns completed the surveys throughout their intern year. A PHQ-9 scale was used to objectively measure depression. Key findings revealed that moderate to severe depression significantly increased from 4.8% before starting internship to 18.8% at 12 months. Notably, female interns consistently showed higher rates of depression throughout the intern year. The study also found correlation between increased work hours and higher depression scores, whereas increased sleep and time off correlated with lower depression scores. Additionally, interns reported higher depression scores during ICU rotations compared to other rotations. I would encourage everyone to read this manuscript because it highlights a critical period in one's training and modifiable risk factors for depression among EM interns. This article highlights the importance of early intervention. It provides important insights for residency leadership and faculty to better support intern wellness in order to prevent long-term adverse outcomes such as burnout, medical errors, and even suicide among emergency physicians.
All right, so I'm going to talk to you next about precision education medicine, a necessary transformation in order to better prepare physicians to meet the needs of their patients by Sally Stanton et al. So this is a different type of article. Mostly what you've heard, with one exception thus far, has all been studies. This is a commentary perspective, meant to almost a conceptual paper to help us think differently. Which I think is actually a really important, nice thing to have into how we approach the medical literature, to kind of think not just about where we are, but how we think futuristically, how do we grow. It does touch a little bit on AI, but I'm not going to belabor the AI piece of it. It's just going to be sprinkled in. But I want to start with a question, which is, if you have the option right now of having Netflix and Apple TV and Amazon Prime, all those on your on your TV, or cable, who chooses cable? Okay, who chooses Amazon, Netflix, everything else? Why? Well, one of the things is we like choice. We like to choose what we want. My 6-year-old who grew up in the era of never having cable, because we don't have cable in our house, but we do have Disney Plus. We went to to my in-laws who still have cable, and they watched a movie. They watched Moana, and there was a commercial, and they lost their minds. They was like, "What? What is happening? No! Fast forward. I want to do this, right?" Because my kids have grown up in an era where we have choice to just skip things. It's not one size fits all. It's not, oh, turn the cable and deal with one. I grew up with cable. I grew up and you turn on TV and you had what you had. I evolved through not liking cable anymore, but I grew up and you got what you got. Precision medical education is a model that's tailored to your learners. The idea of why this exists is to say, we are not one size fits all. What works for me does not work for everyone else. So why are we treating it that way? And so this is a really nice perspective. It actually did two things I thought was really nice. One is it took a concept that was out there and it applied it in a new area. It said, everyone's heard about precision medicine. But precision medical education hadn't quite grown then. So it wasn't that it was a completely novel, never heard of before idea. They took it, they transformed it, and they applied it in a new arena, and they helped us think about something differently. And that's a great way of writing, is sometimes having us just think differently. The other one is that they did some pretty amazing research, because this team is incredible, and Sally Sand is just always solid work. And when we went through it, they started diving in and said, all right, let's talk about precision medical education. And it's a short article, it's a great read, it's worth reading to it. But they did two things. One, they talked through what it looks like. And they likened it to PDSA, Plan Do Study Act cycles, for those on the operations side. And for those on the education side, it's similar to mastery adaptive learning, which we're going to hear about a little bit later. It kind of sits in both those camps with this idea of how do we grow, how do we evolve? And it comes from a couple of key elements. Starts off with data. We have a lot of data. How do we start to siphon through? How do we use, whether it be AI, whether it be some component of natural language modeling? How do we take this data we have in all these EHRs on ourselves and say, let's learn about this. Let's use this data to inform our practice and tailor it to ourselves, because how many EHR records do you all have of your patients you've seen? This data is available. We're just not using it to tailor our education, identify our gaps. Then we use it to summarize what we can use again. This is where AI can fall in here and start to identify themes and saying, you know what? You've been through 4 years of residency and 5 years post-residency, you've never done CRITE. Have you been keeping up on your just-in-time training mental modeling? Or you've seen an overwhelming number of people that are all ESI levels 1 and 2. When's the last time you saw ESI level 4? When's the last time you saw a pediatric patient? Help us identify our gaps. They can provide training and say, how about just-in-time training modules where you say, you know what? You're right, I haven't done a CRITE in 5 years. And so it would be great if I could just pull up a just-in-time training to mentally remind myself of, of scalpel bougie finger. Or to like remind myself of, oh yeah, croup is this. Something to trigger our brains where we're finding gaps that we may not see for ourselves because where the gaps are going to vary. And then I can assess this and say, you know what, I noticed that you've actually had a high rate of admissions for low risk chest pains, or you tend to admit a high rate, or you tend to do a high number of CTs instead of running people with B. And rather than generic, it actually can tailor and use your data to do so. This, I think, is where we're growing, because we're currently still operating in something of a cable mindset, but I don't think we're going to be operating in a cable mindset that much longer. I think there's an opportunity there, and there's groups that have done really cool things. So they brought a couple cool examples. One is they talked about an idea where a group used natural language modeling to look through resident charts and identify the clinical reasoning skills. How cool is that, right? That's not a heavy lift on us, that's not a large language model. It goes through and identifies gaps in clinical reasoning and provides targeted feedback. They talked about another surgical group that put haptics on to see how they were applying pressure during surgery. Wouldn't that be great for central lines? Are we overshooting the vessel? And use this to adapt onto your hand, your ultrasound probe. They've talked about using this, for example, of tracking through residents across their length of the training and mapping their ICD-10 codes against the model of clinical practice to say, you know what, over the course of 3 years, you actually haven't seen very much of this pathology. We should make sure we build this into SIM. These are all doable things. None of this is futuristic at this stage. These are all things that have actually been done at other sites, and we can probably adapt tomorrow to some of our sites with little to no cost. But where they also call us is, and this is where these perspectives are really important, it's not just about where we are now, it's the call to action to the future. And seeing if we're going to evolve, we're going to accept that. We look at Amazon as our model, right? So Amazon as a model, they, Jeff Bezos put a ton of money in there and had zero profit for years. But then it paid off. Regardless of how you may feel about him as a person, as a company, it's a model that is actually successful they invest in there, and became a market leader. Right? And I think when we look at precision medical education, I think we need to accept that we're going to have to invest in it. We're going to have to invest time, effort, money, resources. But if we want it to be better, we want to train our trainees better, we want to give them personalized Netflix-level education that's tailored to what they actually want to do, well, we got to invest in that. And so I thought this was a really nice article to both frame this in a very real sense, but also to call on us, emergency medicine being leaders in so many things, to be the leaders in this, because that's what we do.
All right, so my next paper is Evaluation of Learning in Emergency Medicine, an Umbrella IRB Protocol for Education Outcomes Research. And it's by Dr. Paulson from WashU and some colleagues from the University of Cincinnati. And I would encourage all of you, when you go home, this is what you should be doing. This article is an Advancing Through Innovations report, which is a specific submission category for this journal that has very different subheadings from an original research article. It's a way for authors to describe an innovation, like an educational innovation that they created to address an educational problem. And for those of you who've been here for a few days, I know these authors did a didactic, I think a couple of days ago. And so for those of you who were able to attend that, just think of this as spaced repetition. And for those of you who missed it, I hope you'll really click on this article and sort of, again, keep it in mind for something that you could really apply at your shop even right now. So the problem that the authors were trying to solve was the hurdle of completing the IRB approval process. And because this getting through the IRB sometimes is a barrier for maybe your busy residents or your junior faculty who are just getting into research, this is one barrier for them to really sort of get over that hurdle so that they can do their research studies and really publish whatever it is that they're working on. And I don't know about your shop, but I know that in my institution, it can sometimes take weeks to months to get through the IRB approval process, not to mention the length of time. Sometimes it takes weeks to even just complete the IRB submission because of errors or missing information or things like that. So what the authors did was they describe creating this umbrella protocol for medical education research. In the same way that you might do this for clinical research. So, for example, if you have, several questions, related questions that you might want to ask for chest pain patients in a chest pain registry, right? That is something that you could you could summarize all of them together and create an umbrella protocol and submit it to the IRB, right? Just do it all at once and be inclusive. So you can do the same thing with educational research, right? You just have to create sort of a general protocol, have a data set, and then design this in such a way that it could cover all of the educational research that you do right now, and also future educational projects that come through that you're thinking about. So the authors also describe in this study how they developed this protocol. And one of the things they did was they created sort of these overarching aims for the different research projects. They created a data registry. And so what their objective was to say, okay, how can I create a data set that would give me the best chance of being IRB exempt, right? So lots of education research, if you have no patient identifiers, if you have no learner identifiers, if it confers minimal risk to your learner, then that just, if you gather those existing data already that you are already collecting for your learners, for your CCC or your PEC, those are data points that you could also use for your research projects. And so then they also formed an educational research group, right? So this research group who understood the inclusion criteria for this umbrella IRB, the exclusion criteria for the IRB, this education group can then review and evaluate new research projects being proposed and sort of say, well, would this project fit under my umbrella protocol? Does it fit the inclusion criteria, the exclusion criteria? And if it does, then the study group or the authors wouldn't have to submit a new IRB submission for that research project. So they can just include it in their umbrella IRB protocol. So they created this protocol. It was deemed to be exempt from full review at their institution. I think the main logistical challenge that they faced when they did this was the creation of actually that data registry. Because as many of you know who do medical education research, they didn't have a separate data management administrator, right, to collect all this data as data is coming through about your trainees or your learners, et cetera. They just had their residency administrators, your residency coordinator, who's collecting this data for your trainees. And they didn't want these coordinators to spend extra time collecting data that they might not use for any of their research projects. So I think for anyone who's thinking about doing this, the author suggests trying to think about and create a comprehensive list of data points that you want to collect on your learners during that initial IRB submission. Because the more inclusive you have the opportunity and the support to be inclusive, then any future research projects that come in, then you don't have to submit a separate addendum or a separate IRB submission for those research projects, just because you're collecting new data. So to really try to think about that initial data registry, how can we be comprehensive so that we could really have it applied to lots of research projects and research questions that you might have. So the authors, despite having these sort of bumps in the road as they're implementing this umbrella protocol, having this protocol in place really diminished the administrative burden for resident scholarly projects, for junior faculty who are thinking about doing research, and it's really increased sort of collaboration amongst their faculty just because this protocol was in place. So I encourage you to think about this, think about how you might be able to design an umbrella protocol like this and really try to increase scholarship for your residents or for your faculty.
All right, this is the last article that I'll be discussing. So it's titled What the Experts See, a qualitative analysis of the behaviors of master adaptive learners in emergency medicine. This was an original contribution by a list of authors who I'm sure many have read some of their prior work, they've certainly done a lot of work in this arena within medical education and particularly in emergency medicine. This is a pretty heady med ed paper, so we'll try and kind of go through it and explain some of the methods that were utilized. To start off with, the master adaptive learner is a conceptual model. It's how we believe that a learner can progress through their training and develop adaptive expertise. So adaptive expertise being that where you have the ability to transfer the knowledge that you have and apply it in a new and unpredictable setting. And this typically happens through a cycle of self-regulated learning, and that in itself is a four-process phase that goes through planning, learning, assessing, and then adjusting. And so a lot of words to essentially say what we jokingly refer to as lifelong learning, right? And so what are those attributes that allow us to continue to grow and learn as we go off into the world and are no longer formally in our training periods? And this is particularly relevant to us in emergency medicine, right? Because we are the masters of dealing with uncertainty, right? No matter how long you've practiced for, no matter where you have practiced, you will always come across something that perhaps you have not seen before. And so what this group of researchers did was they wanted to answer the question of what observable behaviors and actions actually define master adaptive learners within emergency medicine. So going beyond just a conceptual model of how we envision that this occurs, and how can we actually see what our trainees who express these skills, what are they doing and what can we recognize? And so this paper, the methodology that they used, they did a thematic analysis through semi-structured interviews. So essentially they did, here they went through and interviewed 17 experts that they selected in the field of emergency medicine. They created an interview guide that they iteratively developed and piloted with certain individuals, and then went and interviewed these 17 experts. And after going through this, they went through an iterative analysis to describe the different themes that arose from this work. And the four themes that they came across, three of them described observable traits of master adaptive learners, and one described the environment within which these traits are expressed. So the first trait was that of critical practice interrogation, and meaning that master adaptive learners compared to their peers are a lot more flexible, and they're willing to engage in feedback in a much more structured manner than those that are not. The second was that of intellectual risk-taking. They're actually willing to be wrong. They're okay with being wrong. And when they're out on shift, they're seeking out discomfort. They're trying to see patients and presentations that perhaps they have not seen before. And then the third was curating an intentional learning network. And so having the self-awareness and the recognition that they can't do this alone. They cannot learn alone, and really tailoring and picking out those folks that they deem can help them progress through their learning journey. The last was not in and of itself a trait of a master adaptive learner, but more so a description of the environment within which we all practice, and recognizing that the environment modulates our ability. If you are a master adaptive learner, I'm not sure if I am or not, but modulates our ability to actually express those traits. And making what they were seeing in their data was that oftentimes the environment within which we practice stifles even those who have those traits and allows them to express them, whether that be because of the way our departments are staffed or structured, or perhaps is it the psychological safety or lack thereof of the environment that prevents learners from engaging in these traits and behaviors. And so what these authors essentially conclude is that first of all, they posit that this conceptual model, there are traits that can be observed. And if we're able to actually observe these traits and be on the lookout for them, then we can begin to start defining at an earlier stage who our trainees are who are expressing these traits, who are not. We can intervene at that moment. We can try and work on getting those who are not fully expressing these traits to start understanding what can we do, what kind of targeted learning approaches can we provide to get them to the point where they are a more self-autonomous, adaptive learner. And really, what can we do to create an environment that is psychologically safe, that encourages learners, even at an early age, who might have some of these tendencies, to feel safe and comfortable to do so in an environment that sometimes may prevent them. And so this is certainly a very broad topic, and one that I think tries to take a very conceptual model that may feel to some slightly more up in the sky and esoteric, and bring it down and be a little more tangible. And so I hope that when you go back into your departments and you start seeing some of those traits that we've discussed today, that you try to continue to encourage an environment where your trainees feel psychologically safe, that they can continue to express those qualities, and perhaps in those that are not, to try to get them towards doing just that.
I will be presenting the last article, Bringing Abstract Concepts to Light, a Health Humanities-Based Approach to Teaching Social Determinants of Health. This is by Dr. Bahara and his colleagues at Johns Hopkins. Can poetry, art, and storytelling teach emergency physicians more about patient care than a textbook ever could? This article is an innovation report and looks into humanities to teach social determinants of health to emergency medicine residents. Acknowledging that traditional graduate medical education often lacks comprehensive training on social determinants of health, the authors wanted to bridge this gap by integrating arts, humanities, and social justice into residency training. Objectives of this curriculum were critical thinking about social determinants of health, engagement with patients and surrounding communities, self-reflection and translation of social determinants of health into their patient care. The authors used current six-step curriculum development framework, which I'm sure many are familiar with, to develop a longitudinal curriculum that focused on narrative medicine, visual thinking strategies, and community engagement. This curriculum consisted of 10 sessions. The sessions facilitated group discussions involving visual arts, literature, and nonfiction works. Sessions were paired with evidence-based data on social determinants of health and their applications in the emergency department. Community-based experiences included sessions with guest speakers and visits to museums and murals. Initially, it was held in person, but due to the COVID pandemic, it went virtually. Results from the participant evaluations really strongly supported this curriculum. The majority found that the humanities is important in residency training, and they noted profound impacts on individual growth, department culture, and patient care practices. I feel that this curriculum is very impactful because it attempts to address gaps in traditional medical education related to social determinants of health. It's an innovative approach that brings together science and humanities. And through reflection and critical thinking, this curriculum helps residents understand and address disparities in their own communities. Most importantly, this curriculum has potential to be disseminated nationwide and adapted to a local context, helping provide a framework model to develop more equitable patient care.
So that was our last article. We just presented 10 articles from 2024, and we hope that this really gave you sort of a breadth of kind of educational topics and some concepts that we try to sort of tease out and bring to this group. We do have some time. We have about 3 or 5 minutes or so. We'd be happy to stay after. We can open these articles up to the group for questions or clarifications from the group. Thank you all for coming. This was really a great audience.